Now, session 3, I'm going to call up Lars Hagander, and he's going to spend a little bit more time discussing the workforce training and education. We felt like we should go into a little bit more detail because you'll notice a lot of the panels will be speaking to that aspect. How do colleges deal with education? How do academic medical centers, et cetera? So Lars is going to unpack our working group to a greater degree than I just did. So Lars, thank you.
Thank you very much.
That is, there you go. Thank you.
Thank you very much. So at the very onset of this commission work, we had a working group on education and training and workforce, and it was headed by Professor Ame from Nigeria, and it was a fantastic team, and it's an honor for me to be representing the works of the group. Several of you commissioners are here today, and some of the advisors as well. I think one of the advisors told us that people are really the front line and the backbone of all these overarching arguments that we're trying to make, like universal health coverage, for example, or health system strengthening. It's all about people, and to achieve our vision, we, as a commission, we really need the people on the ground, adequately trained in the right place at the right time in adequate numbers. So very good. When we talk about, sorry, the green one? Yeah.
Yep. You got to hold it up a little bit. No. The big green. Big green.
Oh, sorry. So when we talk about the workforce for surgery, this is what we mean. This is the definition that we keep in the back of our heads. It's an intricate network of a team that works together. It's not only clinicians, it's non-clinicians, people that monitor, that train, you know, that manage, and we made in the report we make a great effort to stress this. But in the numbers that we present, we focus on fully trained surgeons, anesthetists, and obstetricians because that's the data that's out there. And we try to build our argument from that data and the lack of the data for the rest. So what is the current picture? I mean, we have in the report and in this speech, we have the current picture and the way forward. This is the current picture. This research was done in collaboration with the WHO for this commission. And we managed actually to get the numbers of fully trained surgeons, anesthetists, and obstetricians from 167 countries, representing 92% of the world's population. And so here you can see the density per 100,000 people in different parts of the world. And what this means is that there is 1.1 million specialist surgeons out there. There is 500,000 specialist anesthetists, and 480, almost 500,000 obstetricians. But what doesn't say these numbers is that there is a gross inequity in where these people are distributed, you know, and there are so grave shortages of people in many parts of the world. For example, if we look at different, you know, almost 50% of the people of the world's population live in low-income countries or lower middle-income countries, and these 50% are served by 1/6 of the anesthetists, 1/5 of the surgeons, and 1/4 of the obstetricians. So, particular need perhaps for anesthetists. Or if we look at in geographical terms, 33% of the world's population live in Africa or Southeast Asia, but only 12% of the specialist surgical workforce work there. Migration is one of these reasons. So if we asked 70 countries, high-income countries, how many people, how many specialists do you have and where have you been training? And 12% of people living in high-income countries working in surgical specialties have got their MD from a low and middle-income country. And 68% of those are in a country below the 20, per 100,000 people. So, and what we don't show here is that there is considerable migration from low-income countries to middle-income countries, for example, from rural areas to the city, from healthcare delivery to administration, perhaps. So this is, I think, when you see these numbers, even though that international collaboration is a good thing and that these people, is an asset for coming back, etc., I think it's fair to say that the rich world drain surgical skills from the poorer part of the world. So in this, vacuum of specialists, we have to conclude that from the majority of people in the world, surgical care is either provided by non-specialists, like associate clinicians or trainees or MDs just doing surgery, or they're not treated at all. So What we found in the Commission, except for these numbers, is that the rural surgical anesthesia care is not fully addressed. It's underemphasized in the graduate and postgraduate surgical and anesthetic education, contributing to the maldistribution of surgical anesthetic providers worldwide. We also found that accreditation, licensing, the continuing professional education, those sort of things is not fully described. It's unclear to what extent that kind of institutional foundation for training and education is happening in low and middle income countries. So with these findings, is it possible to achieve the Commission vision of universal access to safe, affordable surgical care anesthesia when needed? And how much is enough? And let's talk about the way forward. You really cannot manage, as John was saying earlier, you cannot manage what you don't measure. So as academic surgeons, we included workforce numbers in our proposed metrics indicators moving forward, and we will come back as academics to check how do we progress the next 15 years. But we're not only talking about numbers, we also put targets. And John described, the rationale between, this is maternal mortality on the left and density on the x-axis. And, we had these densities thresholds of 20, perhaps, or 40. And you can see that, there is something going on there. Just to put this in a context, the research of the Commission also showed that, the operations needed roughly 5,000 procedures per 100,000. Just to show you what 20 means. So if you assume average productivity per surgeon or obstetrician, if you have 20 per 100,000, you don't quite reach, which is in lower middle income country, currently the average of density. You don't really quite come up to what people need. You have to rely on other caterers of surgeons, anesthetists, obstetricians. And if we look at the higher income countries, we are currently on 40. They have a little bit more, perhaps, than this. But then you can allow for a little bit of a rural-urban mismatch, which will inevitably happen, and you can attack the backlog of untreated surgical disease that has been there for decades. Just to put it a little bit in a perspective. So what we propose is that 100% of countries should reach at least this target by 2030. John, you showed these pictures and the scaling up. So, the challenges of scaling up if you see this picture, the red scaling up, you need to have 20 times more surgeons, and it's just very, very difficult to do. And so task shifting is really something that many countries use. It's defined by the WHO as, as the redistribution of responsibilities from highly qualified professionals to those with fewer qualifications. And we found that at least 30 countries employ surgical task shifting, 108 countries employ anesthetic task shifting, and high-income countries are among those countries that take advantage of this. So it's not just a solution, poor medicine for poor people. It's something that we all find efficient to do to some extent. What we do want to stress in the Commission is that we want to emphasize the collaborative part of how you work together. So task sharing is something that we propose. Tasks are transferred from one professional to another to maximize human resources, but both the specialist provider and the provider with less training share the responsibility for a higher quality outcome. A collaborative use of specialist providers and GPs and social clinicians. So we're not proposing that scaling up with task sharing is something that can be done independently of surgical specialists, but you have to be innovative in your way of providing that collaboration. So scaling up with task shifting makes if you count time and money, it's a 40% time and money gain if you scale up with only surgical specialists, traditional medicine, or if you go down the route of 1 in 2 or 1 in 4 in task shifting. So it's a quicker way and it's a cheaper way to move forward. So each country should decide whether task sharing is appropriate for their needs. But if you go in there should be clear scopes of practice. The associate clinicians and general practitioners should be held to a high standard of accreditation, licensing, and relicensing. and shouldn't be to replace surgical specialists. Of course, there are other ways to expand the surgical workforce. We have non-governmental organizations who really should hardwire training programs into their practice, regional and international partnerships, private sector contracting and telemonitoring, etc. So internet before surgery, internet before oxygen. Improving workforce distribution is key. So rural exposure during training maybe is an important thing to make surgeons want to provide care in the rural districts. Local training, rural incentives perhaps. That's absolutely essential to deliver care where the surgeons are, where the patients are. And we have to move beyond numbers, quality of training. How do we do that? Competency-based training, curriculum-based on community needs. We cannot just transplant the Swedish surgical curriculum to elsewhere. You need mentoring, information, and simulation for all cadres of surgical providers, accreditation of all surgical programs, etc., relicensing. So this is the argument that we make in the report. It's not only about numbers. You have to understand the training aspects, and you have to understand, as a country, the entry and the exit of your surgical workforce in order to plan for the future. So we're quite specific about what aspects should be part of your national surgical plan in terms of workforce. Very good. Very quickly, the Workforce Working Group. Thank you very much. Thank you.